Good day, and thank you for joining us. My name is Derek Griffith. I'm the chair of Global Action on Men's Health, and just wanted to welcome you to Global Action's presentation webinar of Out of Focus, the presentation of men in regional and global sexual and reproductive health policy. This work has been supported by Appella, and we're excited to have you here with us today. So just as a quick I'm also professor of family community health and professor of medical ethics and health policy at University of Pennsylvania. And just as a way of a bit of housekeeping, please sign in and using the chat and just add your name and affiliation. We're going to use the Q&A function to ask questions, share thoughts, comments, and so forth. And please join in. We want this to be active and interactive. There will be a Q&A part at the end with the presenters as well as the discussants. The webinar is being recorded and will be posted on the Global Action on Men's Health website and our YouTube channel. It'll last approximately 60 minutes. So why are we doing this? Global Action's main goal is to change global health policy so that it takes better account of men and boys. Sexual and reproductive health is the third big policy area we've looked at really in the last year. In 2023, we published Gone Missing, which analyzed how men are treated in global cancer policy. Earlier this year, we published Absent Minded, which focused on mental health policy. This is the third, and we have more coming later this year, as well as early in 2025. So stay tuned. But today, on World Sexual Health Day, and happy World Sexual Health Day, we're looking at how men are treated in sexual and reproductive health policy at regional and global levels. Men's sexual and reproductive health in general is not good. And for sexual transmitted infections, HIV, contraception, fertility, sexual dysfunctions, or reproductive cancers, men's outcomes are suboptimal, and some groups of men fare worse than others. Our policy reports, Global Action policy reports on cancer and mental health showed similar patterns that men are generally overlooked in policy at the international level. And we wanted to see whether or not this was also the case for sexual and reproductive health. Our report today, Out of Focus, which is actually published today, explores these issues, and its finding will be presented here in this webinar. So the presentation is going to be done by our report's authors, Dr. Tim Shan and Connor Eboy, which will be followed by short comments from 3 experts in the field, and then this will be followed by a Q&A, hopefully with you. Again, thanks to Appella for its support of this project. It's not had any influence over the content of the report or this webinar. Please also consider joining Global Action and our in our networks and following us, joining the organization, following us on LinkedIn, our various social media platforms, and even considering being a member of the organization. So today we're very excited to have again our presenters. Let me do brief introductions of each, and then I'll turn it over to Tim and Connor. So Dr. Tim Shan has worked and published on men and sexual reproductive health for about 2 decades. He's co-director of Shan Clark Consulting, which provides technical advice, strategic support, and resource mobilization to charities and non-governmental organizations working on global health and gender equality in some of the world's most challenging low and middle income contexts. Connor Eboy, an associate at Shan Clark Consulting, is an associate at Shan Clark Consulting, where he has developed various health sector programs targeting men's health, sexual and reproductive rights, and other critical health needs in some of the world's most challenging environments, including South Sudan, Syria, and Palestine. So with that, let me turn this over to Tim and Connor.
Thank you, Derek, and happy World Sexual Health Day, everyone. And it's an absolute privilege for us to be with you today and to present this report. Really wonderful to see so many people online from across the world. And thank you for your interest in this. And there is already in the chat is a link to the full report, and we'll be happy to discuss this further with you and as part of an interactive discussion as Derek mentioned. We'll begin by outlining some background to the report, then discuss the methodology, and then jump into the key findings, and then share our recommendations. It's widely understood that men's engagement is essential not only for men's own sexual and reproductive health, but for the sexual and reproductive health of everyone, as well as for the advancement of women's rights and gender equality. In this field and in much of the work that I've often done, there's been a more predominant focus on engaging men for the sexual and reproductive health of others, particularly women. But there's been less of a focus on men's own sexual and reproductive health needs and men's related unmet needs. And an important step of trying to redress that balance and better focus on men's own SRH is to understand what the policy landscape around this area looks like, and in particular to explore what many of the key global health organizations say in their policies around men's sexual reproductive health, both in terms of their inclusion and men's characterization. This report, as just mentioned by Derek, is part of a broader series by Global Action for Men's Health, building on the two reports he mentioned on cancer and global mental health, which found key gaps in policies as they relate to men.
Thanks, Tim. The report highlights that men have considerable unmet SRH needs globally on STIs. Prevalence of syphilis, chlamydia, gonorrhea, and trichomoniasis is more common in men than women. There have been shifts in prevalence of HIV, with the majority of new infections now in men and boys rather than women and girls. Usage of male condoms and vasectomy as contraceptive methods stands at 25% and hasn't changed for 30 years. Sperm counts fell by 52% between 1971 and 2011, with male infertility now contributing to around 50% of couple infertility. On sexual dysfunction, half of men between 40 and 70 experience erectile dysfunction, with this figure increasing for older men. And for male reproductive cancer, prevalence has increased across the board since the 1980s. The report aimed to answer 4 research questions. First, how is men's SRH currently included in global and regional SRH policy? The second, do policies include sex disaggregated data and indicators on men's SRH? The third, how is sex, gender, and gender equality considered in policy? And the fourth, in policies that do consider men's SRH, how comprehensive is this focus? Our approach to these questions consisted of a rapid review method, developing working definition of men's SRH and key components, and use of a policy data extraction tool. Our data search strategy included identifying and searching key relevant organizations' websites, inputting various terms on men's SRH, and developing a clear definition of policy. This was an iterative process which took into account new findings as we went. From 66 global and regional policy documents sourced, 37 were selected, focusing on men's and women's SRH, sex and gender equality, data and measures, focus on different groups of men, and coverage of SRH topics. Our research had 2 particular limitations, the exclusion and often unavailability of information on policy implementation and on national level policies due to our global and regional focus. As a result of this methodology, we identified 10 key components of men's SRH, which the report focuses on. These are sexually transmitted infections, HIV and AIDS, contraception, fertility and infertility, sexual dysfunction, reproductive cancers, sexual pleasure, relationships, discrimination, and violence.
We'll now move on to the findings, beginning with the overall inclusion of men's SRH in policy. Overall, we found that there was an insufficient focus on this policy. The majority of policies, 57%, did not acknowledge men's SRH. Of the 43% that did acknowledge men's SRH, only 16% deliberately and specifically addressed men's SRH needs, so about 1 in 6 of the policies. We found an overall negative and instrumental framing around men and men's sexual and reproductive health. Men were often presented principally as risks to be managed or solely to improve women's sexual and reproductive health, which is critically important, but nevertheless, there was less attention to SRH as a critical component of men's own lives. There was a narrow focus, not addressing the broad range of topics that Connor has just mentioned, and we will explore further after this. And there was also a limited focus on the different groups of men, particularly the most vulnerable men. Overall, our report found that men are out of focus in the SRH policy context. Where there was good examples of policies, they were often standalone, were not integrated into the broader work of the organizations, and often presented a world in which SRH was synonymous with women rather than synonymous with everyone. In terms of the data and measures on men's SRH and policy, we found that 14% only of policies included sex disaggregated data on men and women's SRH. And where data was included on men's SRH, it was often incomplete, such as a couple of data points or a small amount of information. And there was no single policy that had a more comprehensive set of data points around men's SRH, leading to an actually challenging situation to have a comprehensive understanding globally of men's unmet SRH needs. Similarly, 14% only of the policies we reviewed contain specific SRH indicators or targets for men. And where indicators and targets for men were included, they tended to be specifically on men having sex with men or only in the context of HIV and AIDS. It was more common in policies to have specific data and indicators on women and girls' SRH and health outcomes. And this is important. We're not advocating that we scale back on the strong and the need for greater focus on women's SRH and outcomes, but it's important to have an equally strong focus on men's SRH, given the fact that inadequate understanding and attention to this issue means that men's unmet needs are not addressed, which feeds into practice and policy, which may not be as effective in terms of improving the SRH outcomes for everyone. In terms of our findings around sex, gender, and gender equality, we found that policies overall failed to differentiate between sex and gender, indeed often using the terms interchangeably. And we found an insufficient acknowledgement of gender diverse individuals, reflecting a heteronormative bias within policies. We found men's gendered behaviours and needs were largely overlooked compared to women. And where men's gender was acknowledged, often not explicitly, but nevertheless implicitly, it was a focus on harmful male norms and behaviours as it impacts on others. Again, important as that is, but nevertheless, there was no focus on how men's gendered behaviours and experiences impacted their own well-being. In terms of gender equality, which was a very strong and important focus within the SRH policy landscape, we found policies overwhelmingly prioritise women's empowerment, with only a small number also seeking to engage men to accomplish gender equality or to challenge those harmful gender norms. And we also found, which we believe is critically important, that there was not a connection in the policy context between a greater equity of SRH care, support, and information for men as part of not only improving men's own health, but also improving the health, well-being, and equity of all. We'll now move on to some findings on the specific SRH topic areas as outlined by Connor. Firstly, in relation to sex-age transmitted infections, this was one of the best covered SRH components we found within policy, with both dedicated STI policies that would focus on men, as well as STI included as part of more broader sexual and reproductive health policies. Nevertheless, many of these dedicated policies provided specifically for at-risk groups, which were presumed to be men, particularly MSM, young men and transgender people. There was a strong focus on treatment and care, but nevertheless, we found less of a focus on prevention and behavioural change within STI policies. We found the broader SRH policies that did include STIs often lack specificity, and they referred to STIs more generically with limited detail on men's STI needs. And we found that STI policies would focus on women more than men beyond those specific male at-risk groups and were insufficiently integrated into broader policy. In relation to HIV and AIDS policies, we found that this was the most well-covered SRH topic within the policy landscape, and that policies would focus specifically on at-risk populations, which were, as I say, presumed to be primarily male, generally men in prisons, people in prison, sorry, injecting drug users, gay men, and other MSN. We found only variable attention to young men and an insufficient focus on cisgender heterosexual men, despite the fact that they are key drivers of the epidemic, and we know that men have lower testing and treatment rates for HIV and also elevated AIDS-related mortality. HIV policies were often siloed beyond the broader SRH landscape, with missed opportunities for integration of HIV with other areas, or to utilize HIV as an entry point to engage with men as part of their broader SRH or health. In relation to contraception and family planning, we found that this was very much framed as a female-only issue, sometimes explicitly, often implicitly in terms of the language that policy would use, but it had a limited focus on men's broader engagement. We found some policies did promote the importance of shifting male attitudes and behaviors to improve the uptake of family planning and contraceptive services for women, which is the more traditional area of focus in this topic. But we found there was far less focus on men as contraceptive users, or men's access to services, or comprehensively in terms of men's role as family planning, contraceptive users, partners, and agents of change, which has been shown to be very effective in engaging men around this topic. The male condom was the main male method that was mentioned within policies, and that tended to be more in HIV and STI policies than in family planning policies. And male condoms were principally referenced in the context of disease prevention rather than dual protection that prevents disease and prevents pregnancy. We found a limited focus on vasectomy and the opportunity to increase the vasectomy or addressing some of the barriers to scaling up vasectomy. And we found no specific policy mention on supporting research or adoption of novel male contraceptive methods. In terms of fertility, given the context that Conor mentioned around those particular challenges on infertility, we found only 16% of policies mention male fertility, with a predominant focus on female infertility. And where male fertility was discussed in policy, it was often, or most generally, not comprehensive and didn't cover the broader health implications, such as the potential links between infertility and cardiovascular health. And fertility was generally discussed in clinical terms only, not holistically. Policies rarely address fertility as a couple concern or considered the broader implications and consequences for men and the challenges that men and their partners may face in this domain. In terms of sexual dysfunction, we found that this topic was almost entirely absent from mainstream sexual and reproductive health policy. Only 5% of policies mentioned erectile dysfunction. Where erectile dysfunction was mentioned, it was often just in passing. There was no focus on erectile dysfunction treatment or support options, or the potential for there to be underlying health conditions such as cardiovascular disease. No policy addressed premature ejaculation, and despite the growing prevalence we know in sexual dysfunction amongst older and younger men, these groups were overlooked within policy focusing on this area. And similarly, there was no consideration of the broader mental or physical health implications of sexual dysfunction for men and their partners. In terms of reproductive health, we found that reproductive cancers, we found that male reproductive cancers are almost entirely absent from SRH policy. That includes prostate cancer as well as testicular, penile, and anal cancer. And where these cancers were mentioned, they were not elaborated upon. Female cancers, we found, particularly cervical cancer, received far greater policy attention within the landscape, including both dedicated policies and as part of broader SRH policies. And we're certainly not advocating that that should change, but there needs to be an equally strong focus on male reproductive cancers, given the context and background that Conor mentioned at the start. We also look beyond the SRH policy landscape in this area to look at non-communicable disease policy, which is often where you find a focus on reproductive cancers, not specifically always in SRH. But we found even in the NCD policy landscape that there was an insufficient focus or often no focus on male reproductive cancers. Despite human papillomavirus being the most common entry point for discussion on reproductive cancers within SRH policy, we found that the HPV-related concerns in men were frequently overlooked, or as was the fact that the men are carriers and transmitters of HPV. And then lastly, in terms of sexual pleasure, relationships, discrimination, and violence, we found few policies discuss sexual pleasure for men or for women, or presented this as a desirable SRH outcome. Where sexual pleasure, particularly for men, was discussed, it was often in the context of kind of risky or problematic male behaviors, but not as a positive thing or something that should be supported as part of men and everyone's well-being and broader health. Policies did not highlight the benefits of healthy relationships for men's well-being, and where there was a focus on working with men for healthy relationships, it tended to be for the benefit of equitable relationships for women, and supporting loving, equitable, and supportive relationships is something that only women should aspire to. Policy principally addressed discrimination through a gender equality and women's empowerment and lens, and discrimination as a result against some groups of men or in relation to race and ethnicity was not considered. And in the context of violence, importantly, violence against women was a strong focus, but there was limited focus on engaging men in preventing this violence, and only 19% of the policies acknowledge that men also experience violence, despite the broader context we know and the debates going on around men experiencing violence in conflict or sexual abuse against boys.
We'll now move on to talking about focus on different groups of men within SRH policy. So the SRH of young men, MSM, and transgender people, while these are broadly the best covered male subgroups, they still suffer significant gaps in policy. Only a fifth of policies specifically address the SRH needs of young men and boys, I think 19%. Often policies only refer to gender-neutral young people's SRH or make a blanket reference to men and boys, which fails to account for the different SRH needs of men and boys. MSM's SRH 90 needs are well addressed in HIV and STI policies, but outside of these areas, MSM are not referred to at all in SRH policy. Likewise, for transgender people, policies focus on HIV and STI related concerns, but only one policy reviewed provided a more holistic approach to trans people's SRH needs. Similar to older adult men, the SRH of young men and boys is out of focus on policy. On older men, disabled men, and men with serious health conditions, these groups are almost completely neglected in SRH policy, despite their increased level of needs. 1 in 20 policies contain specific references to SRH provision for older people, including older men and women. This may reflect a reluctance to consider the sexuality of older people from global policymakers. Disabled men are completely neglected in global SRH policy, and similarly, men who are living with or surviving serious health problems are not considered at all in policy. Policies are more likely to address the SRH needs of women and men with serious health conditions, such as cervical cancer, as touched on by Tim.
So in conclusion, what does this all mean? So we recommend that there needs to be an increase in the policy focus on men's own SRH needs, moving beyond the more limited focus on men's involvement to increasing men's own access for the benefit of themselves and everyone to SRH information, services and care. We should adopt a more positive approach to men's and women's SRH within policy, which positions SRH as a critical component of men's lives. Expand data collection to include the sex disaggregated data as standard, including more detailed data on men's SRH needs, and include targets as well as measurement of men's SRH. We, in the report, share a proposed definition of men's SRH as a contribution to supporting the broader data collection in this area, and we hope that a standardized definition on this topic could be agreed to strengthen support and analysis across policies. We believe it's critical to continue to address the implications of harmful male gender norms, particularly as the impact on women and girls, and to seek to minimize the frequency and the negative impact of these norms. We also believe it's important to meaningfully engage men in challenging these harmful gender norms and to promote gender equality and women's rights. We call to strengthen the distinction in policy between sex and gender and approaches that address greater gender diversity in policy, as well as greater recognition of men's own gender needs and behaviours, to further expand the focus on men's needs within policy on HIV, STIs and contraception, to increase a policy focus on the more neglected SRH topics that we've presented on here, particularly sexual dysfunction, infertility and reproductive cancers, to expand a more positive focus on SRH for women and men through a greater focus on healthy relationships and sexual pleasure, to expand the policy focus on addressing discrimination, particularly racism, and against particular groups of men, continuing to focus on reducing violence against women, and to recognize the impact of violence that men themselves experience. And lastly, to better reflect and address the SRH needs of different groups of men, particularly older men, men with disabilities, men with serious health conditions, as well as transgender people, and to include more specific and explicit rather than solely implicit at times references to cisgender heterosexual men, a greater focus on younger men, and a more comprehensive approach for men who have sex with men. Thank you very much for the opportunity to present this. Thank you to Global Action for Men's Health, Opella, and Weber Shanwick, and all the team. Back to you, Derek.
Thank you so much, Tim and Connor. Yeah, really appreciate the wonderful presentations. And now we'll move to our panelists. So let me introduce our three panelists. Dr. Morna Cornell is Senior Research Officer in the Center for Infectious Disease Epidemiology and Research in the School of Public Health at the University of Cape Town in South Africa. Dr. Elna Rudolph is President of the World Association for Sexual Health, and she's from South Africa. And Dr. Dominic Shattuck is an associate scientist in the Johns Hopkins Bloomberg School of Public Health and co-chair of the Interagency Gender Working Group's Male Engagement Task Force. So welcome all three of you, and thank you for joining us. I don't know that we worked out an order. I know I listed you all in a different order than what we initially discussed. So I don't know which of you wants to go first.
If no one is offering, I will offer to go first. That'd be great. Thank you so much. And thanks for having me as part of this webinar. I really appreciate it. And I really appreciate the work that Tim and Connor put into this report and their review of all the policies and the way in which you all went through this process to come up with some results around what policies are happening globally right now around sexual and reproductive health. One of the things you referred to in the foreword, I think, or a part of the report was it called it a no man's land. And the findings in the report validate the statement by providing evidence that most reproductive health policies, they just simply weren't designed to improve men's sexual and reproductive health. And as you acknowledged earlier, we understand why this is the case. You know, women get pregnant, they assume the greatest amount of risk. They also, almost all contraceptive methods are designed for, or are women controlled, I should say. And historically, women shoulder the burden of reproductive health responsibilities, and most often after the child is born too, for the care and nurturing of those children. But fortunately, over the last 50 years, we've seen some shifts in how you know, not only reproductive health services have made great strides in maternal and child mortality, contraceptive uptake, and the management of the HIV pandemic, but also in some interpersonal dynamics within the home too. And we're at a point where these sexual and reproductive health policies should begin to reflect the shared responsibility among women and men, while still maintaining women's autonomy. The figures presented by Tim and Connor in the report sparked the need to consider the design of these sexual and reproductive health policies. And over the last couple of weeks, I was thinking a lot about what these policies should look like from the perspective of the work that I've implemented, which overlaps a lot with work that Tim has done in the past as well. And the report provides some great recommendations to this effect. And so from my experience, you know, one of the things I'll be looking for as these sexual and reproductive health policies roll out in the future and are modified are two specific areas of focus. And the first is to ensure that policies make provisions for the integration of new male-controlled contraceptives. So not only do we want there to be services for men, those services to increase, but how do they consider those male-controlled contraceptives? And second, how are we going to use this moment and the shifting of these policies and whatever programs and systems and services are delivered to better understand the changes in health outcomes? Are we going to see some additive effect in terms of contraceptive uptake? Are we going to see an additive effect in terms of reduced maternal mortality and child mortality or infant mortality? So currently, right, there are several male-controlled contraceptive methods in development, and you can learn more at the Male Contraceptive Initiative website. I'll drop the link in the chat after I'm done. And the methods range in form and function. So as policies are reconsidered, their design should be inclusive of language that facilitates the integration of these methods. And as you may know, this isn't a simple task. You know, it's not just they make them and pass them out. So, I mean, there's more that has to happen. And part of that is without a solid foundation of sexual and reproductive health service and service delivery for men, the male-controlled methods won't be utilized. So also the report is working on the assumption that more, and I heard Tim mention this earlier in his presentation, more comprehensive integration of sexual and reproductive health policies is both equitable and beneficial for families and communities. Okay, so through research conducted by myself and others, I understand this to be true. Those studies have identified the positive relationship between gender transformative interventions and increased contraceptive uptake. What's interesting is that many of those studies also result in meaningful secondary impacts, which are seldom reported. Those secondary impacts include men's increased responsibilities within the home, their increased positive engagement with children in the parenting role, and women reporting improvements in their relationship, including more autonomy and input in household decisions. These are also important and meaningful changes that need to be included when we start to design the monitoring and the evaluation of these programs as they're coming out. And I know Tim and Connor made a reference to that earlier in their presentation. But before I pass it back to the hosts, I wanted to share a finding/anecdote from a project I led in Rwanda. So the project included the national scale-up of vasectomy, and I talk about this all the time. So at the end of that project, we had more than 2,500 men who received vasectomies. And during the evaluation, we asked hundreds of the clients where they learned about vasectomy. It wasn't from their buddies at the bar or their colleagues at work or from the radio or the healthcare provider. Their most frequent response was, I learned about vasectomy from my wife. We know that women are more frequent users of the health systems around the world, and reproductive health is inquired about sometimes even when a woman's visit isn't about contraceptives or pregnancy. And I believe that this finding contextualizes the value of reproductive health counseling and care across entire communities. We shouldn't view it as we shouldn't view this as only avoiding pregnancies and educating about STIs. Engagement around sexual and reproductive health is also the on-ramp for accessing other health services. As we approach these policy revisions in this way, we can anticipate changes around men having more consistent conversations about their health in general and their reproductive health with providers and with friends and colleagues, or colleagues, maybe not, but friends. And we should be looking for increases in their trust in the health services. Simultaneously, increased contact between men and providers should elevate providers' ability to communicate effectively with their male clients. And if this is done with a gender equity lens, it can also increase men's support for the medical needs of their partners and their children. The gaps highlighted in the report are in some ways expected, and in every way, these gaps are limiting the health outcomes of women, children, and men together. I sincerely appreciate being a part of this presentation today and part of this webinar, and I'll pass it back to Derek. Thanks.
Thank you. Smorna Elna.
Sure. Hi. So I wanted to start just by congratulating the authors for producing what I think is an excellent, unbiased, and directly useful report on a really critical public health issue. Thanks also to Global Action for commissioning it and for giving me the chance to comment briefly. So first of all, I found it so refreshing to read an in-depth report that actually foregrounded men's own sexual and reproductive health needs. Just remarkable. And secondly, I thought that the focus on global policies and on how men are represented in these was entirely appropriate. And I also really appreciated the inclusion of sexual pleasure as a key but missing element of policy. So on the first point, as the report notes that SRH is still largely seen as a women's issue in the policies in the same way that we know gender is still largely equated with women in global health or global policies. And men and women are clearly still seen as competing populations. So to read a report which assumes that men have the right to sexual reproductive health and then seriously interrogates these critical global policies with that lens was a first for me. And it's very exciting, I think, for many of us who've been trying to raise the profile of men's health for many years. And the second point, I thought that the focus on global policies and the way men are represented was absolutely spot on. The way we do or don't talk about men has enormous implications in terms of health access and outcomes. And global policies, we know, in particular, have a huge impact on what actually happens on the ground. We know that the funders, international health agencies, national programs even, are using these to identify gaps, to set their priorities, to allocate funding, and to design programs and interventions. And unfortunately, as the report confirms, first men were absent from SRH policies, and then they were included in a few policies, but largely in an instrumental way to protect women and represented as risk factors. It's quite startling. It should be more shocking to read facts like these in 2024, that only 16% of the policies focused on men, that only 14% had SRH indicators for men, that the WHO SRH portal has no indicators for men, and that SDG 3.7, which defines access to SRH services, also doesn't have any indicators for men. And unfortunately, it doesn't surprise me. I've worked in the field of HIV in South Africa since 1992, first as an activist and then as a public health epidemiologist. Over the past 30 years, I've seen a continued, and some even call it systematic, neglect of men in public health responses in Africa and globally. So in South Africa, we've got the highest number of people living with HIV globally. We've got about 7.7 million people living with HIV in our country. And in our initial responses, men were largely absent. So women were characterized as vulnerable, as innocent victims, as lacking in agency, part of the characterizing as well, and prioritized then for care. And in contrast, in explicit language, men were characterized as powerful, hypersexual, violent, and vectors of disease, and so implicitly less deserving of care. And so by 2023, we had similar proportions of men and women who tested for HIV, and those among those who were on ART who were virally suppressed, but a much higher proportion of women than men starting treatment, 84% versus 75%. And in a context of really high HIV prevalence, that equates to a lot of men who are not receiving treatment. And it's not limited to South Africa. We see similar sex disparities in HIV programs across sub-Saharan Africa. And yet, despite the body of evidence, almost nothing has been done to address major gaps for the general male population living with HIV. And that's obviously bad news at two levels: for the health of those men and for public health responses, because we can obviously forget about ending AIDS and all the commitments to doing this if we're actually not looking at men's needs and integrating these into global policies. In terms of one minor gap in the report, which I really thought, as I said, was just so comprehensive, it considered many, many different groups of men. But I would have also liked to have seen some more consideration of how policies address the needs of men who've been marginalized by socioeconomic status and by history. So, for example, in Africa, millions of men have been marginalized by absolute poverty, by enforced mobility, and by the long history of colonialism and then apartheid and migrant labor that tore families apart and disempowered millions of men. It's clear from this report and from what we know that men have been represented in these important, the way that men have been represented in these really important policy documents sets the scene for SRH programs to continue to ignore men, right? And it has to be challenged. I think this report provides powerful evidence to call for a radical review and revision of all global health, SRH and related policies, including and especially the highly influential, highly biased SDGs, using a public health and human rights lens to address gender bias and to support good sexual and reproductive health for all genders. Thank you.
Thank you. Elma.
Thank you very much, Derek, and thank you for the invitation and the opportunity to be here. It's an honor for me to represent the World Association for Sexual Health, which is a global confederation, and we are focused towards professionals who work in sexual health and rights. And it's also our vision, sexual health and rights for all. And therefore, a report like this is so important because, as we know, the pendulum has swung. The SDGs are focused on improving the lives and health and plight of women and children. And it is such an integral part to their health and rights to also make sure that men's health is on board and their rights. And I want to commend Global Action on Men's Health and also Appella for sponsoring this very, very important work. It's so good for us as the World Association for Sexual Health to be busy with all the things that we are doing, and then kind of out of the blue, such an important document emerges. And I know it's not out of the blue at all. It takes a lot of work and dedication. And we are very interested at the World Association for Sexual Health in global standard setting. So we would be very interested to continue to work with you guys to see which of these reports you could see as kind of a gold standard, something that we could set as the standard for other organizations, for other policymakers, since policymaking and especially evidence-based, rights-based, scientific policy is what is at our heart. And I was also, of course, we published the World Declaration on Sexual Pleasure, and it is fantastic to see that you did focus on pleasure. And today, being World Sexual Health Day, our official theme for today is positive relationships, and it is also good that you guys focused on that in the report. So what I would also want us to look at in future is the impact of genital altering, voluntary and non-voluntary genital altering on men's health. So that's the word that we use these days for it at the World Association for Sexual Health, as opposed to circumcision and all of the controversy around the circumcision of boys, and then also what's happening with traditional circumcision in men in Africa and the consequences of that. So a future, maybe something that could be added on that, because we would like to see that there is actually firm policy on this, rights-based policy on this, and they are very big role players in this debate globally. Genital autonomy is a very contentious issue, but we'd like to see some clear directive policy on that globally as well. I've made quite a lot of notes on everything that was said here, but I think I will rather hand it over back to the rest of the panel. Thank you very much.
Thank you, and thank you all three for your wonderful comments. Before I turn it back, before we open up for Q&A, let me make a comment, and then I'll turn it to Tim and Connor to have any comments or reflections on what's been said. Then we'll open up. I do want to just note, so if you can, take your questions that are in the chat and put them in the Q&A. It's a little hard to kind of move back and forth between the two, and in the interest of time, we only have about 15 more minutes that we want to use to maximize that time. Some of the comments also, we have to remember, reflect limitations of the reports that they reviewed, not limitations of the report. So you have to remember their goal was to actually review what is existing in these regional and global policies, not to create new policies. So some of the topics that are being raised are things that were limitations of the existing policies. And so that's important. The report did review regional and global policy. It didn't include national policy. I think they mentioned that, but I think there was a question in here about that as well. So I just wanted to quickly sort of answer those couple of comments. So Tim and Connor, do you have thoughts or reflections before we open it up?
Mainly just to say thank you so much, Dominic, Morna, Elnan, and Derek, for those really insightful reflections. I mean, I think the one thing that excites me about this conversation is, and I think you kind of touched on it, Morna, is, how do we move beyond kind of seeing men and women and, and people of other gender diversity to, being as competing. And I think, those of us who've worked on men's sexual and reproductive health for a long time, there has been movement on really thinking meaningfully about this issue, particularly as men play a role in impacting the health of others, especially women. I think it really is an opportunity for us to try to move beyond those silos or those perceptions of opposition to say, if we can really redress what is, an inequity in access to care, to information and services, and focus on men in their own right, as you said, in the context of contraception, as Dominic mentioned, in the context of HIV, as Mona mentioned, in the context of healthy relationships for the benefit of everyone, as Elna mentioned, then that's not just good for men, it's good for everyone. And I think that, we haven't yet got to that stage where we really position men's own needs as something that's good for everyone. And I think that would, and hence, I think that's why you find such a barren policy landscape around so many of these topics, which directly impact on men's health, but have an equally significant impact on their partners. But we don't really explore and discuss that. So yeah, I think there's a lot of work to do and really exciting to do it all with you. Don't know, Connor, if you.
No, I echo Tim's thoughts, and likewise, I want to say a big thanks to everybody for your really fascinating contributions. So yeah, thank you.
Great. Thank you both. So let me jump to the Q&A. I'm going to go to a question that I'm going to paraphrase because it's written rather long and thorough. But the question is, do you have reflections on needs to change at the health system level to improve, to take advantage of what we're learning about the need to focus on men in sexual and reproductive health policy? And I guess this is particular in the context of low and middle income countries, frontline providers that are often women, and those who are not, and anybody who typically is not trained in addressing men's health needs. So I apologize, Mary Phillips, if I butchered your question, but I think I got the gist of it. So any thoughts or reactions to that question?
Do you want us to dive in now, or do you want to make a couple?
Yes, please. All any of the four of you, or I'm looking at 4 screens, 5 of you, please. Yes.
Yeah.
Yes, morning, please.
So quite a lot of work has been done on this on some projects in Malawi, which have been basically also trying to understand how you get men to test, how you keep men in care, etc., in a context of extreme poverty, very mobile population, climate change, those kind of things. And obviously also part of the issues were healthcare workers' relationships with men, and the fact that generally speaking, they didn't have many male clients. And so there's been a whole curriculum being developed there about working with healthcare workers to actually improve their interactions with male clients, so that they're actually learning what are the issues, what are the problems for men, and how could it also better improve their care with the men, building confidence in the healthcare workers, increasing the likelihood that somebody would come back to a health facility. They found that one of the single biggest predictor of whether a man would return to a health facility for care was how he was treated. So there are some fairly simple initiatives that are now being tried out also simply at that level of just being able to actually teach the basics of being welcoming, being respectful of men as clients, because there is a deeply entrenched prejudice against men as clients of the healthcare system. So that's just one thought about what's happening. They've developed a curriculum, a locally applied curriculum, and they're busy piloting it now in routine care.
Tim, Connor, I think you were about to comment as well.
I mean, I think just to kind of caveat again that this was a look at a global policies, and there was a question in the chat around kind of which institutions, and just to kind of touch on that in answering this question. So we looked, for example, the World Health Organization, UN agencies such as UNAIDS, many of the big international donors, USAID, FCDO, the East Africa Community, the Africa Union, the European Commission, the European Union, organizations that inform policy such as the World Association for Sexual Health that's on the call. So at global and regional level, you don't tend to get the kind of specificities on kind of service provision. But I know from my own work in places like Malawi and South Africa, reflecting what Mona said, and Dominic's on the call as well, we've done a lot of work, that I think that basically the same challenges that we've outlined at a global level are reflected in these national level policies and in the implementation. So if the national policies on, whether it's STIs or HIV or contraception, I know that from my own work on contraception, don't necessarily see men as people who will use services or engage with services, and that trickles down to the implementation. So I think that, at the very first stage is really for these policies to more meaningfully acknowledge and address men, as sexual reproductive health being a critical component of their own lives. And then to think about what that looks like and to look for opportunities. And I think what happens as a result of that gap is you get often unregulated responses. You get often responses which actually do more harm, reinforce gender inequalities rather than necessarily engaging directly. So I think policies around service provision have a long way to go, and it's at all levels. Just to say lastly, of course, it's the education of the provider, it's the context of the setting, it's the information provided to men, it's norms and attitudes and behaviors and inequities in communities, as well as the broader institutions and organizations. I remember meeting with a senior member of staff in a Ministry of Health in a government who told me that we can't really worry, or she said something like, we'll focus on men when we've solved all the problems in relation to women. And of course, and that was like a senior member of staff. And of course, again, recognizing at the highest level of policy making that there is an opposition there, where in fact men and women's sexual and reproductive health lives are intrinsically linked.
Yeah, I think to add to what Tim was saying and Morna was saying earlier, it really, when you work in communities, especially in LMIC countries, you're oftentimes you hear women in the community saying, "Hey, why aren't you working with men as well?" So they come to you and they'll say things like, we need to kind of buffer this conversation. We need to have ways in which our husbands or our partners or the young men in our lives who are just becoming, starting to date or starting to be interested in girls and women. I mean, this is, or other sexualities. I mean, they realize that there's a gap. They feel this gap, and they feel this gap in real ways in their lives. When we think about integrating these services, whether it's male contraceptives or whether it's just even counseling, there's such a humongous distance in many ways from getting many men into health clinics. It's not going to be a silver bullet that's going to solve this problem. It's going to be a number of different interventions for different types of people. We know from a lot of different programming that's been implemented. Personally, I had some epiphanies during the COVID pandemic when we started to message about vaccination, that one type of messaging doesn't reach everybody. So you need to diversify that messaging. You need to diversify the channels in which the messaging is being delivered. And you need to make sure that you're checking in with people to see if they're getting exposed to those messages and whether or not they're salient to the needs and challenges that are facing their lives. The male contraceptive methods are going to have a pretty steep hurdle, or a pretty steep hill to climb, I should say, to kind of get into the mainstream. But it's going to take a foundation of service delivery for men across the board for that to actually happen. Because if you realize, as we know, there's a book that we refer to often. It's called, I have it on the shelf over here, Contraceptive Technologies. It's like 800 pages long, and it's got every contraceptive method. I think the last time I checked, I think it was 48 pages of that 850 pages are actually focused on male controlled methods. So if you think about the myriad of options that women have, and that the physicians have been trained in those options and how to counsel them and for years and decades. And I mean, that's all good stuff. How do we build on that, and how do we make it better? And sorry, please go ahead, Elena. Elna, sorry.
Oh, yes, please.
Thank you. Now, in my day job, I have a private sexual medicine clinic in Stellenbosch, in a very affluent area. And in South Africa, men still earn much more money than women in this area. Particularly, you still have many women who stay at home out of choice, and the men can afford these kind of services. But what I see in my practice is that less than 20% of the people who do opt to use my services would be men. So the barriers, you would have thought that this is a highly educated environment. So you would have thought that those barriers had actually already been removed. But even in a very affluent situation with educated people, men do not access the services. And something that we are very interested in at the World Association for Sexual Health is comprehensive sexuality education in school and out of school. But I think that is a place where we can start with this. If it's the one place where we have equal amounts, or even if not more in certain societies, men and women in the same location. And if we can think carefully about the messaging that we have there to actually drive them into care and to drive them to be the agents of change that we know that they can be, and to give them the authority and autonomy and not take it away from them and make them vectors of disease, etc. I think it can be very powerful. And not only comprehensive sexuality education within schools, but then also when you go onto tertiary level, where the leaders of countries are being educated, we think it's extremely important to get good SRHR messaging to everyone at university level. And, you know, not only in the humanities, throughout all of the different courses at that university, we think that it's important to get messages about sexual health and rights to everyone there, because those people become the leaders, they become the policymakers. And if they don't understand this, like from the cradle, it's very difficult to go and convince them of those things later on. So I think there's hope, but there's a lot of work to be done.
And that's very consistent with actually one of the comments in the chat, that there was a comment from Benno that talks about the education sector is even more important, or I guess equally important, to the health sector. And so I think that aligns quite well. In our last couple of minutes, I want to give you all opportunities to just say any final comments or thoughts. Morna, I'm going to come to you first, then Dominic, Elna, and then Tim and Connor.
I think on reflect, if you had to take these reports and you just had to swap women and men around, and we had to report stats like this about women, there would be such an outcry. It would be cause for such urgent attention. And yet, year after year after year, various people have been banging away at this drum and trying to change this. And the documents, these policy documents that are so incredibly important, are so biased, and they have to be challenged. And thank you. I think this report goes a long way to providing really good evidence to challenge them.
Dominic?
Yeah, so on an earlier Global Action from Men's Health webinar, we had a speaker, and please forgive me for not remembering her name, but she told us the value and the importance of telling the stories behind the policy change you want to make. So I gave a quick anecdote from that vasectomy project. Find your story around this topic, around these policies. How are men impacted by not having the policies in place so that they can access the services that they need and support their family in a super positive way? And tell that story. Write the blog, tell the story, tell it in your meetings and your presentations. When you have the data, put the story behind it, because that's what's going to change these policies. So let's collectively kind of walk away from here figuring out what our stories are, whether it's my story about the vasectomies or it's something else that you've come across in the people you interact with. Maybe you're a provider, a clinician, and you're working with men and you're hearing the gaps and how they talk about, I don't know what it is, but find that story and tell that story and link it to the lack of policy and services that men have in this space. And also link it to the benefits that women will have down the road and their families will have as men are more integrated into the services and care. Thanks.
Thank you, Dominic. Your story inspired me. I am definitely going to remember that. When we get to sit at the seats in UN meetings with WHO and wherever we go as the World Association for Sexual Health, this report and being part of this webinar has definitely reminded me of the importance of men's health in SRHR. So thank you for the work that you've done. It's truly meaningful. And I believe that the recording of this webinar will still go far and change many policies globally. Thank you very much.
Thank you. Tim and Connor.
Well, thank you. I think an experience that will always stay with me was being in the male wards in a hospital in Blantyre, Malawi, talking and holding the hands of men who were at death's door. They didn't know their HIV status. They'd accessed treatment far too late. Their family members, their daughters, their partner, their broader family were sitting around their beds, not knowing what's happened, not knowing why it's happened, scared for the future, the man himself scared for the future, and only then testing for HIV and not knowing that he was an HIV positive when it was too late. And I think it's important that we remember that the cost of men's ill health is not just felt in relation to sexual reproductive health by men themselves. It's felt by men's partners who don't get the infertility care that they need. It's felt by men's broader families if we lose men too late, and it's felt by broader society. And so I think we hope that this report can be a springboard for policymakers to look at these policies and to review them again, and most importantly, to expand on them, particularly addressing the gaps that we've identified on issues and topics and groups. And also, we hope all of you will take this policy away and continue the amazing advocacy work that you do as activists, as practitioners, as academics, as women's rights champions in this field, to continue to push for broader policies and really to provide some focus on an area which is very much out of focus. So thank you very much indeed. It's been an absolute honor to be part of this conversation. Anything?
Yeah, I noticed a question on mental health. Just very quickly to touch on that, I thought it wasn't a major focus of our policy, but it did come up a few times. We did sort of consider, and there's a major gap there in relation to SRH and its impact on men's well-being, mental health. We know, and we expand on this in the unmet needs section within the report, but we know that poor SRH has a massive measurable negative impact on men's well-being, and I think that this is I would just echo the concern of the person who left the question on that. It's a vital issue, and I think it's something that deserves a lot more attention. So that's all from me. Thank you.
Well, thank you all. Again, presenters, panelists, thank you all so much for your thoughtful comments. Thank you for participants for, again, engaging quite well. Sorry we couldn't get to more comments and questions, but definitely a rich discussion that is hopefully only the beginning, not the end of our discussion of these issues. Please do continue to support, follow, and join Global Action on Men's Health, and continue to do work in this space. And again, happy World Sexual Reproductive Health Day, and have a wonderful day. Thank you so much. Bye.
Thank you, everyone.